Thank you very much, Marta. My pleasure to be here. Thank you very much for this invitation. Actually, I should mention one thing. It's my pleasure to come back to the Maudsley Forum. I was in the first Maudsley Forum in London, 2003, when I did my PhD. And so it's more than 20 years ago. It's my second time in Sicily, my first time in Palermo. Thank you for this opportunity. That's true. My grandmother, my nonna, is from Cortina d'Ampezzo, and I got Italian citizenship. Parlo poco italiano, sorry. I will talk about treatment-resistant depression and focus on ketamine, you know. As Marta said, I'm leading the Maudsley treatment service, that I'll talk a little bit about that. I have some conflict of interest in this talk, you know. Yeah, that's better now? Thank you. So this conflict of interest are related to some grants, and, but also mainly to drug companies, and also I got a patent from ketamine clinic approach with oral ketamine and subcutaneous ketamine. Let's start from the beginning. You know, my first point will be to talk about a little bit about depression. You know, you have seen several interesting talks this morning from Fiona and our other colleague from Ireland about eating disorders, amazing talks. But depression is a problem. Mainly this concept of major depressive disorder. In this editorial, some colleagues mentioned about the high heterogeneity of depression. And definitely this is really something like, I like this picture because you can see different men here using the same jacket. You know, that's the point, that major depressive disorder have so small effect size, and the research inconsistency is really a big problem. Finding biomarkers in major depressive disorder is a problem. And so we have these difficulties in developing new drugs. You are happy that you are living in an area that you have new mechanism of actions, new medications, new neuromodulations approach for this that is the most burdensome of all medical disorders. When I moved to this country, not this country, but to UK, I contact Professor Eugene Peiko. He was a full professor in Cambridge. Some of you possibly know him. And I said, Professor Peiko, I'd like to study this interesting paper that you mentioned about residual symptoms can predict relapse. And if you discharge someone with residual symptoms, the probability is 3 in 4 patients will have a relapse. If you discharge them without residual symptoms, just 1 in 4 will have relapse in 9 to 10 months, you know. So this is amazing to do that. And then, unfortunately, Professor Peiko was retired, and then I went to King's College, and I'm still there until now. Another good idea to understand depression is this concept developed by some colleagues from the Imperial College, that they describe at least 2 different types of depression. Depression with loss of interest in energy, so people that have lost pleasure, lost motivation, low energy, loss of interest. And the other group with more anxiety, depression, guilty, irritability, fear. And these 2 groups, of course, the treatment-resistant that I'm talking possibly have both, but if you see this group possibly have more loss of what they call the positive effect, that are more linked with a decrease in the positive effect, because you think happiness is positive. Interest in pleasure, energy, enthusiasm, self-confidence are positive. And these are really mediated with the dopaminergic circuits. So this decrease in positive effect definitely impact in a depressive disorder. But the other group, of course, you know, anxiety is quite prevalent and comorbidity with depression. And this group have most of the time serotonergic input, and you have irritability, loneliness, anxiety, and fear that are mediated. And this is the point but this is the diagrammatic, you know, is a diagram for depression that do not solve the problem. You can use this as a strategy to treat, giving input for some of the patients, but this is lead us to our current state of clinical practice, that 30 to 50%, depends on the settling, you have treatment resistant. And this is, will lead to what you just saw about most severe and chronic medical conditions. You have a higher impact of treatment-resistant depression. And so this is also associated with several problems in our service. And not only the cost, but also life, like we know that this is impacting in the most lethal of our clinical practices is suicide behavior. Professor Hush, that is a bright mind, developed this concept in the 90s about treatment-resistant depression, and possibly his most important study recently was about the TRD that most of you already know. You have at least two pathways about treatment-resistant depression. Failure to respond. It varies, but most of the time two different antidepressants at the right time, the right dose for the right period. But you have also another one that is neglect, that is the failure to retain sustained response. And so focus exclusively on the acute treatment trial and forget about these sustained response. And so fail to capture this proportion is an important point. And so because depression is a lifetime disorder, you need to consider the longitudinal course of this disorder, you know. And so the same John Hush developed this new concept that I would like to introduce. And possibly this could be the best title of my talk today, Difficult to Treat Depression, Reconceptualization of TRD. So because TRD comes from the concept of medical disorder, and so you a cure or not cure, respond or not respond from oncology mainly, but other medical disorders or other medical illnesses, acute illness model, mainly biological, and the approach is cure. So I'm just telling here, Martha, about the conceptualization of TRD, and this concept developed by the same author that developed TRD, that is John Hush. They propose that the difficult to treat depression is a more collaborative concept between patient, family, and physician, and is a model not of acute illness, but a chronic illness that can integrate biopsychosocial recovery, optimize and improve the quality of symptoms, you know. You have at least 3 dimensions. This is just the TRD is here, treatment factors, because treatment-resistant depression is not a diagnostic, it's a treatment history. So you cannot put the label, oh, you are TRD. No, you have a treatment history that you not respond to some different treatments for combination of different medications, combination of psychotherapy. I have used some types of neurostimulation. You do not have adherence, you do not have a tolerability for the medications. So this TRD, treatment history, treatment factor, in the difficult to treat depression, we integrate some personal factors, the personality, the genetics. You have a great talk from my colleague from King's tomorrow. Childhood trauma is a quite important point, even for psychosis, psychosocial environmental situations. So integrate the treatment factors, personal factors, and the wellness factor is a unipolar, is a bipolar. One of our colleagues studied with me atypical depression, melancholic depression, early onset, chronic course, recurrent, comorbidity with psychosis, comorbidity with alcohol and drug abuse. So these give us a much better picture why this patient is difficult to treat, you know, just not only the treatment history. Based on this introduction, we started 6 years ago with my colleagues, Professor Alan Young, Professor Tony Clear, the Mousley Advanced Treatment Service for difficult to treat affective disorders. And so the Mousley, we put the service inside the Mousley. It's not easy to have a space at the Mousley, but we are happy to and lucky to develop this specialized service to approach difficult to treat depression, treatment-resistant depression, treatment-resistant bipolar, and we can offer them review. You usually contact the community mental health teams in South London. In South London live more than around 2 million people, and these people usually have several community mental health teams that need some input from specialists about the diagnostic, the treatment recommendation, the follow-ups. And you can offer this approach regarding complex psychopharmacotherapy, neurostimulation, ECT, vagus nerve stimulus, VNS, and what is our focus today, antiglutamatergic agents. In different forms, you can provide the already approved in FDA and MI, that is ketamine intranasal, there's Bravato, but also ketamine IV, ketamine subcutaneous. I will talk a little bit about one grant that you develop, oral ketamine, and sublingual lozenges ketamine as well. We also try to develop treatment resistant approach to improve the skills and approach from these community teams, and also develop several clinical trials, you know. One of the things that is good for this service that you are living a period that you have these new pathways, because for more than 50 years, we live just working with the monoamines, so adrenaline, dopamine, serotonin, and now you have a better understanding about these pathways and new medications that are coming that are working with glutamate, that will be our focus, but also related to stress and HPXs, GABAergic, opioids is another important point, cholinergics, and also this process of epigenetics, genetics, neuroendocrine definitely is our area. You talk a little bit this morning about neuroendocrine approach, immune dysregulation, and then you understand better the neuropathology, neurophysiology of depression. Glutamate is one of the focus of our talk today. We know that glutamate is the principal excitatory neurotransmitter in central nervous system. Is quite important for learning, memory, metabolism, and more than 60% of the total brain activity will be stimulated by these neurons, you know. So it's really important to understand and how we can modulate these in these patients. I should say that we know more about stress, neuropathology, neurobiology than depression. You know, when you study stress, we know that stress will impact in the HPA axis, hypothalamus, pituitary, adrenal axis, releasing some hormones. You talk a lot about inflammatory depression, but this is inflammatory depression is a marker for the HPA axis most of the time, because our main anti-glucocorticoid is cortisol that can possibly impact in these. And so we usually work, this look like more complex, but it's not so much if you pay attention. Half nucleus, you know, is the central main concentration on density of serotonergic circuits and locus ceruleus noradrenergic. You are working most of the time with antidepressant in this area here. You are not considering the HPA axis, other hormones of the HPA axis, not only cortisol, but you have aldosterone, noradrenaline, and the feedback that will impact in cognitive areas like hippocampus and amygdala. So these are quite important. And then you have also the importance of GABAergic circuits in this area, you know. And now you can integrate here, modulating these cognitive areas, the glutamatergic neurotransmitter here, you know. So this is important to keep in mind, that stress alterate this area, alterate this neurotransmission, and we know that people that suffer from stress, life events could be recent life events, recent life stress, or even childhood trauma, early life stress. Definitely, if the patients do not suffer abuse, they respond much better to treatment. If they suffer abuse, the response is even lower. And talking about longitudinal response and remission, you have similar results. The patients that do not suffer any kind of abuse in their childhood, they respond much better to the treatment. So stress you should consider as a key factor for treatment response, you know. And so the focus today is ketamine. And so you have been using ketamine in several routes, you know, as I mentioned. We start using sublingual dosing of racemic ketamine. We have several clinical trials with drug companies about S-ketamine nasal spray. Since 2019, you are using other forms, not only IV and subcutaneous. It's much easier to use subcutaneous, and the bioavailability is almost the same of IV, you know. So you are giving the preference to using in most of the patients subcutaneous. You still have some using IV. You have the intranasal ketamine, and we have also sublingual tablets lozenges. That is something that I'll talk a little bit more. In oral ketamine, that you have a trial that you developed recently. So these decisions usually are made with our team and community mental health teams. You are in tertiary care in the Maudsley hospital. This is the ECT suite that you adapted also for the ketamine clinic. The patients arrive there, and so in the room that you usually deliver the ECT, you also prepare the medication. You have 3 beds. Most of the time, the patients stay around an hour here if they receive IV, subcutaneous, or ketamine. They should be fasting, and then you have another room to offer them some tea and coffee if it's necessary. The main point that you should not forget about our experience with psychological approach, like you should not forget our experience with serotonergic approach, because we know that ketamine is an adjuvant medication that can combine really well with SSRIs, SNRIs, and other medications, you know. And you know the mechanism of action of these impact, because you have some correlation between serotonergic fiber that can project in neurons in the prefrontal cortex, augmentation and increase the glutamated neurotransmission. So there is some impact here, you know. I should say, Marta, that I believe that ketamine is not a psychedelic. I think there is some studies that have overlapping. Ketamine have some mechanisms of action that are similar to other psychedelics, but they have several other mechanisms of action that are distinct from psychedelics. Let's start from the beginning. It was discovered in the 60s, was approved in the 70s from FDA as an anesthetic agent, and in the 90s was discovered to be a medication that can really impact in patients with treatment resistant. And different from other antidepressants, the effect was really short and immediate in effect, you know. Carlos Zarate, that you are just writing a good collaboration with him in the National Institute of Mental Health and assessing and analyzing some trials, developed the first studies randomized controlled trial in the 90s and demonstrate this clearly. In a single dose, this effect was just 7 days. So rapid onset, but short-lived. Antidepressant properties in the single dose of IV, ketamine IV. After that, several new NMDA antagonists are developed, including the pharmas. Just to give a picture, the glutamate activity, this is the optimal glutamate activity for healthy people, you know. If you use ketamine or esketamine, you are using an antagonist of an NMDA receptor. If you use other partial agonists, you can also change the glutamate activity as well in the other side. So, the main mechanism of action you can see here is try to block this NMDA receptor and then release the inhibitory activity of GABA, and this is will possibly in an uncompetitive antagonist increase the glutamate release acutely and then increase the cascade that I mentioned before. You also have some metabolites that are quite interesting and can help these patients as well. The mechanism of action is really something that possibly can be better understood in the future, but it is a complex. As an anesthetic, have hypnosis, have psychomimesis, have analgesia, and antidepressant is our topic here today. Modulating glutamate, noradrenaline, dopamine, is a multimodal. It's a multimodal approach, you know. So you have impact in opioids that we'll talk soon, and also can change gene expression as well, you know. We can say that when you are try to improve depression, you are impacting, as I mentioned, the HPA axis. And you know that the hypothalamus are quite linked with some opioids and reward system, you know. So there is also not only the glutamate here, but also some endogenous opioid system. And this was quite interesting study that you are developing now, that if you use naltrexone, as you know, blocks ketamine, antidepressant effects, but not dissociative effects, because naltrexone is an opioid receptor antagonist. And when you use here naltrexone, ketamine plus placebo, ketamine plus naltrexone in orange here, you see the Hamilton scores is still the same. You know, the patients do not improve; they still above 20 points in the Hamilton. That is a moderate to severe depressive episode. But when you are combining ketamine with placebo, the depressive episode, according to the Hamilton, decreased dramatically in the first days. The dissociative effect, because this is the reason that possibly some people put ketamine as a psychedelic, because is an anesthetic that gives dissociation in the beginning, do not change, you know, when you are blocking the naltrexone. And so what we know that ketamine acute antidepressant effects, but not dissociative effects, require activation of the opioid system. This is important to know, you know. You can give a medication for so long if you are activating the opioid system. What is the impact of this activation for a long period? You know, you should consider that. Coming back to the first studies of Carlos Arati, you can see he gave one dose of ketamine, and in the first 20-30 minutes, this is less than 4 hours, and in the first day you got a significant change comparing with placebo, but after 7 days come back to the normal. So you can see these as well with rapid reduction of suicidal ideation with ketamine IV. Unfortunately, the drug company could not see these with ketamine intranasal. This would be a blockbuster if you can give an intranasal spray in an emergency and then save lives that are trying to commit suicide. But unfortunately, this is not the case, was not confirmed. But we can see exactly that with IV, you have a severe decrease here. Patients with severe suicidal ideation have a significant decrease. If they are unipolar, they have a severe decrease, a dramatic decrease if they are bipolar as well. This is open label, controlled by placebo, and this is, we can control with active medication, you know, giving benzodiazepines, for instance, because when you give ketamine for a patient and give placebo, we will know that the patient will know that he is receiving ketamine. But when you are using active placebo, like midazolam, you can see also the decrease in the back suicide inventory here, in the Madras suicidal ideation score here as well. So this is just with IV and subcutaneous, you can see that. One of the things that we know that is not all depressive symptoms that can improve with ketamine. We know that sadness is something that the patients really report that they are improving. Cognition is another interesting point that they mentioned. The concentration improved. Doctor, I feel much better to read and to pay attention to things, hold a conversation much better. Inability to feel as well, you can mention. This is the items of the Madras, but you cannot see in long term, 2 weeks time, you know, the symptoms that they have higher score in the first day. After 2 weeks time, they do not change too much. Pessimistic thoughts, inattention, appetite, suicidal thoughts, and sleep. Dissociation and family history of alcohol is something that can possibly impact in this response. Less sadness is also something interesting. And trouble in concentration at the day is one of the predicted of great response in these patients, you know. Sleep is not really a quality that can really predict a good response in 2 weeks' time. A good response is, I think, was not a coincidence, Martha, that you put me after eating disorder talk, because we know that patients with high body mass index, we have a greater response with ketamine. So this is an interesting point that you should consider about the mechanism of action of ketamine. And we are developing now an NHR trial with ketamine for alcohol and drug abusers. So you have patients with family history of alcohol use have a good response in a prediction of response. As you can see here, suicide attempt is not a good response for these patients, you know. But for all, you should say that the response combining the intranasal with antidepressant is much higher than you have seen in TRD. It's almost 70%, you know, comparing with around 50% with placebo. And the remission as well is much higher. Remember, the TRD, the remission is around 30%. So is a good tool. It's not like clozapine, Martha. I thought that it would be like clozapine when I started studying ketamine. You know, you have the solution for treatment-resistant affective disorder patients, but unfortunately, it's not like that yet. But maybe you can discover other things based on these findings. We are understanding now, when you start the first time that you use ketamine, in the first day, you see a dramatic decrease in the Madras score. And then if you repeat this, the patient usually have a relapse of some symptoms 4 days, and after 7 days, it increases. And then if you use another dose here, you have another decrease. And this is usually the course of repeated dose, you know. You have not seen a big difference using comparing 3 times a week or twice a week. So usually the course is similar in the decrease of the baseline scores. For this reason that we developed this trial here, try to understand better the pharmacokinetics of oral ketamine. In our practice, usually you give once a week the injection. The patient comes to us once a week or twice a week in the beginning. And then the other days, they can have oral ketamine or sublingual tablets at home. And this is make a better course of the illness and decrease the risk of relapse. We got this grant from Elcom to develop the oral capsule racemic ketamine, and we investigate the tolerability of this immediate release ketamine oral in men and women and assess the metabolites of them. This was a trial with middle-aged men and women, no health controls, no history of anxiety, bipolar, normal to over 8 BMI, no history of suicide attempt, no evidence of drug abuse, and we use dose from 40 milligrams to 240 milligrams to oral doses of ketamine. And so you assess several pharmacokinetics and pharmacodynamic data. And for our main findings, I should mention that you have the pharmacokinetics really proportional to the different doses. The pharmacodynamic is also dose-related, and the dissociation are observed at just 1 hour. So it's quite safer to have oral ketamine than have ketamine IV or subcutaneous, you know, because the metabolism and the pharmacokinetic is longer. And the safety was really well tolerated by this. And then you use these pharmacokinetic results similar to effects of other ketamine formulation that were studied for longer, like ketamine IV and the intranasal ketamine. Just to give a big picture about these findings, this is our finding with ketamine release. You use the lowest dose, 40 milligrams, and the highest 240. You can see here comparing with the Spravato ketamine. So our dose of 240 is something between 2 devices and 3 devices. So and with a lower dissociation and similar pharmacodynamic effect, you know. And if you compare our ketamine, oral ketamine with ketamine IV, is similar, you know. Usually you use ketamine IV 0.5 milligrams per kilo IV, and you are comparing here with almost our peak of 200, 240 milligrams. So it's a similar kinetics, similar pharmacodynamic with lower side effects and safe to use, don't need it to be used in a hospital like IV, intranasal or subcutaneous, you know. This is an inter-study published in the New England Journal last year comparing ketamine nasal spray versus ketamine in TRD. We have, using the 2 devices or 3 devices of the intranasal, you know the pattern to use is Bravato is twice a week in the first month, once a week in the second month, once a week or each 49 in the following months, you know. And ketamine extended release used from 50 to 300 most of the time. And so you have seen that this augmentation with ketamine have a better outcome in a long term of 8 months compared with quetiapine. So this is the state of art we are at the moment, you know. Ketamine is a new paradigm, you know. It's not solve our solution about TRD or difficult to treat, but definitely is something new that come to better understanding about the neurobiology and the physiopathology, and the clinical studies demonstrate that this has a rapid and lasting significant antidepressant effects for these patients, and determine how ketamine should be implemented long term and how long you should use. Possibly this will be one of your questions. This is $1 million question, and the answer is $2 million question, possibly, because you don't know exactly how long you should be using this to manage chronic depression. But consider this as a strategy should be important. I should answer and maybe emphasize here also, because my talk is focused on ketamine, but we should think about difficult to treat and treatment-resistant depression, that definitely neuromodulation is really should not be neglected, you know. We know that there are several studies try to demonstrate that the comparison between ketamine and ECT, and several studies like this published in the JAMA Psychiatry last year demonstrate that in just 5 studies that compare head-to-head, ECT is better than ketamine for these patients with a depressive episode. You know, the findings suggest that the advantage of ECT over ketamine. If you move to some other studies that can possibly include more randomized controlled trials published this year, because you try to say ketamine is the solution, is better than the most potent of all treatments for depression, and the answer that we have at the moment is no. Analysis suggests that ECT is superior to ketamine plus ECT, and superior to placebo, as you can see. As the first approach, ECT for sure have definitely the first position in this ranking, you know. Ketamine, just a few approaches can demonstrate this. On the other hand, possibly some of you know this paper that was published last year in the New England Journal of Medicine that tried to demonstrate that ketamine was not inferior to ECT as a therapy for treatment-resistant depression without psychosis, Fiona. Just patients are depression without psychosis. They use ketamine 3 times per week and ECT 3 times a week as well. No, ketamine twice a week and ECT 3 times a week, you know. And then they use the right unilateral and ultra-brief pulse. And definitely the limitation of this trial, several letters to the editor tried to address that the ECT was start with the unilateral, and you know that bilateral have a better efficacy. They use ultra-brief pulse that can prevent cognitive problems, but definitely will have a lower response. They can use more sessions. They have good maintenance. It's an open label. And so that's a trial that possibly tried to have some bias to reach these conclusions, and the previous meta-analysis and systematic review do not confirm this paper, you know. In the same journal, they published a very interesting review 1 year ago. My good colleague and great researcher in the field, Charles Kellner, tried to mention that ECT is essential treatment for severe mood and psychotic disorders, support the evidence and efficacy and safety. And in the last 15 years, and so you are lucky to live this area, new treatments are coming, VNS, TMS, intranasal, ketamine, but comparing to new treatments directly to ECT, you should not consider replacement to ECT in this severe and resistant patients. You know, ECT definitely reduce the risk of suicide, improve the quality of life, and decrease the rates of hospitalization in these patients. So ECT for sure need to be considered as a treatment for these patients. I have several fellows that come from Italy. You know, Marta mentioned that my ancestors all come from here, and this guy, this Italian Ugo Serletti, discovered ECT in 1938, and I know that ECT is not so used in Italy. You know, it's a pity, and you understand the reasons, but it's not the case to go deeply in this. But he developed the first studies in manic males, and so this is interesting. It's not only for unipolar depression, but patients in a manic phase of bipolarity can also have a great response, like catatonic patients as well. So in the 40s was found to be effective in depression, and since that have been used in a broad spectrum for illness and symptoms, you know. Of course, in the 50s you come from this medication, but it's a pity that it's not so used in Italy, and maybe this conference can help to increase the use and indication for ECT as well. This guy here is possibly one of the top researchers in this area, Harold Sacken, and he mentioned that no treatment pharmacology or otherwise has matched ECT in speed or remission of major depressive disorders. You know. So this is the point. We published recently something about lithium. Lithium is another great possibility for augmentation in treatment-resistant patients, and so we should also consider more evidence for augmentation for lithium in first instance, and even in low dose, like you publish in this paper, low dose around 0.6 or even lower have significant benefits compared with placebo as an adjunctive therapy for patients unipolar treatment-resistant depression or bipolar depression as well. You know. The other point that I should mention, you should consider and do not forget old medications like monoamine oxidase inhibitor. I know that it's quite difficult to use Maois here in Italy. You know, you cannot drink red wine, cheese, and not have parties like that that you are listening outside. Yeah, Maois possibly is something that could be a good indication, but for 5 minutes break, guys. You can look to the window now. You can look to the window now. That's Marta, please.
I mean, it's going to go. I don't, because otherwise we can't hear you anyway. Yeah, I know, they're leaving. Yes, I thought it was a strange time to do a concert. So, but you know, it's actually a nicer way than protesting than No. I don't think Scientologists are good musicians as they are. Yeah, they've gone. So I think enough of Sicilian protests. We can go back to treatment-resistant depression.
And so we're talking about treatment-resistant depression. I mentioned about lithium, monoamine oxidase inhibitors, old medication, still the most powerful. And you have also phenelzine, tranylcypromide. Don't try to use moclobemide. Definitely moclobemide have a lower efficacy, not reach the steady state. And then you should consider this prior to ECT, that is the most powerful one. My colleagues in Newcastle, Newcastle, almost in the border of Scotland, developed what they call the Newcastle cocktail. They combine monoamine oxidase inhibitors with the precursor of serotonin, L-tryptophan, and lithium. So this is interesting, this kind of cocktail is a pharmacological strategy for treatment-resistant patients, and you should consider to use this. Maybe I can give you more details how much you should put in this cocktail later if you like. Just to conclude, and maybe you have some questions and comments, introducing the possibilities of new treatment strategies will be important. You should consider that ketamine is an advance. The new medications that are coming are advanced. They are using different mechanisms of actions. But you should not forget about the previous one, And so neuromodulation, neurostimulation, old medications can have a great impact in the most severe case, And this will help us to improve the management and go beyond. You should consider also no conventional drugs, because these patients are quite severe. They have several treatments, they're not improving, they have suicidal behavior, several inpatient treatments, and you need to try to understand how you can improve their quality of life and consider them as difficult to treat, not resistant to treatment. Another important point is like this difficult to treat, that you should try to improve the quality of life in the specific episode that you are living, to consider that depression is a chronic disorder, and the goal will be improving this quality of life, and consider other no standard treatments. I'm not following exactly the guidelines, but in some patients you need to go further the guidelines, So it will be important. In the future, you are in a theological, how you say here, Marta? Faculty theological, and I believe the future belongs to God, and then the immediate action will be possibly what you're looking for, but improve this psychotherapy will be important, engage the patients in psychotherapy, the medication will be important because they are in a chronic and long-term episode. And what this Australian colleague said is important, because you should not label the patient as treatment resistant, It's better to say that it's difficult to treat them, but we can help them, instead of say, I can do that, I cannot do that. And so this is my whole message for you today. You published this paper with Alan, this book with Alan Young some time ago, have some topics about we discussed today, and you just released now, yesterday, this clinical textbook about mood disorders, and I hope you can possibly have, this is one you can access on PubMed as well. It's in chapters, in articles. And I'd like just to thank you for the invitation. It's my great pleasure to be here.
Mario, maybe you can use this microphone to answer a question. Thank you very much for a great talk. And I'm sorry to suggest that ketamine is a psychedelic. It's just that I know you are collaborating with colleagues on psychedelics, so I wasn't sure if you were going to discuss it all. I have an anecdote. I know the effects of ketamine on mood because Robin had 2 major surgeries a few years ago, quite close to each other. And after the first, he really struggled to recover after the anesthetic. He was in a very bad mood, didn't want any food. The second time, 10 days later, I could tell he got ketamine because as soon as they called me to say I could go and see him, he was sitting up, he was very cheery, chatting to everybody, wanting food, and had a very speedy sort of recovery. So even on the basis of this completely anecdotal experience, I could say definitely there is something about ketamine and mood. But one question I have is really about how many studies now you have that have looked at the sort of, if you like, management, so long-term treatment with ketamine in the different modality of administration, because I'm thinking a little bit about when I used to work with people with depression as a trainee, and we would do ECT. And you know, there are some people that have a spectacular response to ECT. The problem is that when this is the only treatment that responds and you have to get ECT for life, the price you pay in terms of cognitive function. So I wonder, there you go. I was just talking about you and ketamine. And you appeared to witness that I didn't lie. So I wonder what the long-term studies are in relation to effectiveness and tolerability. Oh, sorry, no, we didn't.
Thank you, Martha. But I think that the first point regarding ketamine is not a psychedelic. This is a controversial point. You know, several people will think that but as I try to demonstrate, the mechanism of action is a little bit different from most of the psychedelics that you are studying, psilocybin, LSD, and ayahuasca. But we believe that ketamine have this effect in the opioid system that is really impacting the HPA axis, and so this is the reason to make a little bit different from all the drugs. And it's an anesthetic that give dissociation, give pleasure, like you just give an example from Professor Murray, anecdotal experience. Maybe he can talk more about that later. One of the things that you mentioned is about the long-term use of ketamine. So this is, I think, because the response for ketamine is similar to ECT in several points. You know, you will not have a good response for ECT for personality disorders. Patients with personality disorders do not respond to ECT. Patients with panic disorder do not respond to ECT, and the same with ketamine. If you give ketamine for patients with primary UPD, borderline, they do not respond. If you give patients with panic disorder, they have a very bad trip most of the time, you know. You can have a good response in the combination and comorbidity with depression and anxiety, but this is the primary resistance. And the time that you need to possibly prescribe this is a problem to answer now. In our studies now, you are trying to use this combination of, in very severe patients, of ketamine subcutaneous and this oral ketamine that you are developing studies with treatment-resistant, difficult to treat depression, and now with bipolar depression as well. So in this trial, you try to follow them in a year. There's not so many studies that follow for more than a year. The drug company Janssen developed studies for more than a year with ketamine intranasal. They try to demonstrate that these patients stay well for more than a year. In our experience, I'm not sure if it's the impact of Camberwell, South London. They could not stay longer than this, you know. When you stop for more than 3 months, usually they have a relapse. We have some patients that move to Devon across the sea. They are enjoying their lives and their
and
then you can stop and decrease the dose, and they are recovering much better. But this is also open and clinical experience. You need to do a proper clinical trial. But we think that this combination for the most severe, combined with injections and 2 times a week, the oral ketamine, can help them to stay longer well, and then you need to try to measure the impact in their lives, you know. I think this is the main message, you know.
Thank you very much, Mario. There is a question online. In the shown comparison, quetiapine, ketamine, the quetiapine group also seemed to respond quite okay. What is here the definition of treatment-resistant depression? Well, we decided we're not going to talk it treatment resistance, but anyway, Mario.
Yeah, this is a trial that was published in the New England Journal of Medicine last year, and they demonstrate that quetiapine have a good response as well. We have a clinical trial that was sponsored by NHR. The PI is my colleague Tony Clear, and you have seen that quetiapine have a better response than lithium as augmentation in this trial. This is a change in the paradigm, what I just said to you. You know, lithium is the one that have more evidence as augmentation for treatment resistant, and in this trial, quetiapine have a great response and a good tolerability compared with lithium. Now you are reanalyzing the data, comparing the levels of hypomania in these treatment-resistant patients. But in this trial, the ketamine have a better response, as you have seen in the graphic, you know. So this is demonstrate a long-term good response combined with other antidepressants. The main point is that are not using alone, you know. When you are using quetiapine, you are combined with other antidepressant. When you are using ketamine or ketamine, you are combined with another antidepressant. Most of the time, SSRIs or SNRIs.
Thanks, Mario. It's great to hear about the fantastic work you're doing in maths. Now, in your maths days, you worked along with Robin and myself in the National Psychosis Unit. And as you'll know, we very frequently get referrals for people who have depression as part of their illness, either a depression alongside their schizophrenia or sometimes a psychotic depression. Are any of the new approaches that are being considered where you would like us to pay attention to? Is there any emerging science that we should be aware of for people with depression in the context of psychosis, I'd say either primary or secondary?
That's a great question, Fiona. It was my great pleasure to work with you at the National Psychosis Unit some time ago, and I learned a lot at that time. My point is that your question come to me, and one of my students is now developing a meta-analysis about this, and I have seen that ketamine and esketamine do not increase the psychosis symptoms in patients, you know. It can give some dissociation in the very beginning, but is not impacting patients with psychotic depression, psychotic mania, or schizoaffective patients. You have not tried to see schizophrenic patients, but patients with the spectrum of affective disorders do not have any impact in their dissociation that can possibly impact the psychopathology of their psychosis. And so you hope to publish this paper soon and possibly try to demonstrate that we can use these in patients with psychotic depression, psychotic mania, schizoaffective patients in a positive symptoms, you know.
In the first place, thanks a lot for your speech, very interesting, very stimulating. I'd like to ask you if in your unit you have any data or experiences regarding the use of dextromethorphan in difficult to treat depression. Thanks.
That's a good question. There's a new combination of dextromethorphan with bupropion. You know, I didn't mention here bupropion, but you know bupropion is a dopaminergic agent. It's not licensed in UK for depression, but the Royal College support the use of bupropion. And most of the countries in Europe, US, Canada, South America, and Australia are using bupropion as an antidepressant, a dopaminergic medication that can help. And recently there is, I think, approved dextromethorphan combined with bupropion. You have it using some patients that come from us to US and Canada. You have seen good results with this combination of dextromethorphan that is also antagonize the NMDA receptors and improve the symptoms in a similar mechanism of action of esketamine and ketamine.
Hi, Mario.
Hi.
Pleasure to meet you here. Thanks for your talk. Are you aware of, or are you conducting yourself, any studies that go beyond just the pharmacological level and thinking about the mechanism of action and the hippocampus and the effect of meditation on that, not specifically meditation, but using complementary methods to treat difficult to treat patients?
That's a good question, Sylvia. You know, most of the studies with psychedelics that Marta mentioned in the beginning are using psychotherapy as an approach. You know, usually they have most of the time one dose of psilocybin and other drugs, and have a great support from psychotherapy. In most of the studies that started in NIH and have a collaboration, as I mentioned, with Carlos Zarate, they just give an injection and do not have any kind of psychotherapy approach. When we started the service 2017, almost 7 years, 8 years now, we have seen that we need to try to engage with the patient in a psychosocial way. So we try to develop. I did my CBT training with Aaron Beck and Judith Beck also before becoming a psychopharmacologist, And I try to also always use my skills as a CBT therapist to engage with the patient, try to manage with the core beliefs and automatic thoughts to help them. And now you're coming the drums higher. I try to speak, yeah, indeed. And the next point is you have now 2 psychotherapists that are doing with us behavior activation. And one of them is finishing his psychoanalytic training. And so they are using some skills also. I really believe that the combination of psychotherapy approach is important for these patients with this chronic disorder, so severe, so traumatic in most of the time.
I've got 2 questions. I hope that's okay. My first is, I wondered if you could clarify, you made the comment that people with personality disorders tend not to respond to ketamine. What specific symptom would the ketamine be targeting? What about people with personality disorders is not treatable with ketamine?
That's a good point. You know, I mentioned that I work with Fiona at the National Psychosis Unit, and before that I was a consultant in the MAP treatment team, Mood, Anxiety and Personality treatment team in Lambeth, is a borough in South London. And they have a great approach for personality disorders, UPD patients, emotional unstable personality disorders, borderline, narcissistic personality disorders. I work in the main field of bipolar and depression, but you have this collaboration. And you have seen that medication do not help these patients. For sure, they need DBT and other approaches. The medications can help to improve the anxiety symptoms, the depressive symptoms, but will not treat the psychopathology of their personality disorders. And so this is the main point. When you receive some patients with severe UPD or borderline, you assess them and you try to help in the complex psychopharmacology to improve their symptoms, but not to treat the psychopathology that need to be treated in long-term psychotherapy approach, you know.
So it would aim to treat anxiety and mood symptoms, but it doesn't?
Yeah, definitely you can help with the anxiety and depressive symptoms. You can try to decrease the suicidal behavior.
So I guess that's the central thing that I was hoping to clarify. In personality disorders literature, they tend to use the term negative affectivity instead of treatment-resistant depression, and they're quite difficult to extricate from each other. And I kind of wonder whether, if the term negative affectivity was used, whether it might kind of draw the personality disorders community into the ketamine treatment tent.
Yeah. We already tried this, you know. This is the point. You have some interesting tables in International Society of Bipolar Disorders that can compare the different diagnostic. That is difficult, as you said, comparing bipolar and borderline personality disorders. They have several overlapping symptoms, bipolar and borderline. But you have some skills to develop. I wrote a paper that maybe I can share with you, that you try to understand the neuroendocrinology of bipolar and the neuroendocrinology of borderline, and correlate this with the early life trauma. So early life stress is much higher in personality disorders than in borderline. Than in bipolar. So borderline have a more severe history of abuse and neglect comparing with bipolar. It's more biological, less environmental disorders. Professor Catherine Lewis know that 80% of the bipolar have irritability and receive genes from the previous, and personality disorders do not have this genetic so clear at the moment. And so the main point is we not have a clinical approach, psychopharmacology approach for these patients now. We can talk more about this. It's a great question.
Mario, as a connational of Ugo Cerletti, who developed the ECT, a comment on ECT. I mean, it's true that in Italy ECT is available in very few places. Honestly, I am unable to say anything about what this means in terms of missed recoveries or other negative consequences. But my point is a bit different. I think that any discussion on ECT should be very cautious, because I very well know the literature on RCT, comparing true ECT with sham ECT, starting with the historical outstanding Northwick Park ECT trial done by Eve Johnston, Tim Crow. And many of the RCT trials show that excluding few patients with, for instance, depression with psychotic symptoms, there is very little difference between true ECT and sham ECT. And about use of ECT in other clinical conditions out of depression, I'm extremely skeptical, and I absolutely don't think that ECT has any demonstrated efficacy. So while I'm convinced that ECT in a number of very restricted conditions should be granted to patients, I'm also convinced that for many other conditions there is an overestimation of the real ECT efficacy.
No, for sure. For like all treatments, you should have the right diagnostic and the right indication. This is the main point. But there is clear evidence that the best indication for ECT is treatment-resistant depression. So you have severe depressive patients that do not respond to other things that can respond to ECT. The second best indication possibly is catatonic patients. So catatonia is definitely patients that are not eating, not drinking, have a great response with ECT. And as I mentioned, manic patients as well have a great response. Saying that, I should also mention, based on your comment, that we have some patients that do not respond to ECT and respond really well to ketamine. And you have exactly the opposite. Some patients that do not respond to ketamine and respond to ECT. That is our topic here. So this is come to our personalized point, you know, you should try to do. And one of my PhD students now is doing exactly this. Try to predict who are the responders and the no responders. You are assessing them based on the neuroendocrine assessment in a long multi-center study that you are using also neuroimaging to predict at the baseline who will be the responders, who will be the best indications. You are comparing depressive patients with catatonic symptoms and depressive patients without catatonic symptoms. And then you can predict who are the responders for that. But like all medications, you need to have a good indication.
Well, you guys have piqued my interest now. It sounds like you can't, it's difficult to get ECT in Italy, and I think at one point you said, oh, and we know the reasons, but we don't know the reasons. So why is that? Why is Italy not much for the ECT?
I'm not sure. Maybe the Italians can say more. I'm just, my nonna is Italian. I don't know too much about Italian.
I would suggest this is for a lunchtime chat. So 2 seconds answer and then lunchtime.
ECT has been widely abused, used in patients for whom there was no indication at all. There is the popular image of ECT given without anesthesia, raising a lot of objections and allergies. And then all the movement of democratic psychiatry has generally seen ECT as a sort of torture, which is of course not the case, but this has become a sort of dominant dogma, and it's very difficult to change this dogma.
Do you think Basaglia has some impact in this?
Professor Barbera here? I wondered if you wanted to say something. Anyway, lunchtime, you want to chat about ECT, you're welcome. Otherwise, I will stick to the nice food that you will be familiar with, and then we'll back actually to hear more from Professor De Girolamo, but not about ECT. So enjoy your lunch, and for those of you who have missed it, this is the password for the Wi-Fi for today and tomorrow.